Series of lectures on therapeutics relevant for the MRCP Part 2. The first lecture will be on complex management of cases. This is relevant for those questions that come up in the exam. Let's go to question number 1. Mr. S presents with a 6-week history of feeling unwell and very lethargic. He is a known hypertensive. His wife tells you he has been rather stressed at work recently and is drinking fairly heavily. As a child, he was found to have an abnormality in the structure of his heart, but she's not sure what this is. In the emergency department, he has 2 generalized tonic-clonic seizures, which are treated with intravenous lorazepam. Blood results on admission are shown here. You can see a raised bilirubin and abnormal LFTs. In addition, you can see that his white cell count is slightly elevated. His INR is 1.4 and his platelets are slightly low. Which one of the following drugs is the best choice for the long-term treatment of seizures? Valproate, lamotrigine, gabapentin, Keppra, and carbamazepine. The right answer is lamotrigine. I'm sure this is an unusual answer to you, and so I will explain each one in turn. Valproate is probably what you would have considered. I wouldn't use valproate because he has abnormal liver function tests. With gabapentin, again, gabapentin is not really used as treatment for epilepsy, it's used as an adjuvant. Keppra is used not as a first line, and so you wouldn't use it here in this case as a first line anti-epileptic, anticonvulsant. Carbamazepine is not great with generalized seizures, as well as in patients with AV conduction defects, and we're told that he has an abnormality in his heart. And that leaves us with lamotrigine as the most appropriate long-term treatment. I would not use a benzodiazepine for long-term management, although none of those have been put here. Let's now consider question number 2. A 30-year-old lady with known recurrent attacks of migraine presents to the emergency department complaining of chest pain. She normally takes amitriptyline and started sumatriptan for an acute attack. She has just returned from a holiday in Spain. Her examination is normal, with all observation within normal range. Initial blood tests reveal normal hematology and biochemistry. Both D-dimer and TROP-T assays are within the normal range, and the chest X-ray is normal. Which one of the following is the most appropriate course of action? Would you start heparin and arrange for a VQ scan? Would you obtain a psychiatric opinion? Would you stop the sumatriptan? Or would you arrange for a gastroscopy? Or would you just reassure her and discharge her? I'm not really concerned about a pulmonary embolus in here, so I'm not really considering A, because it was a short trip to Spain and we're not told about any immobility or any risk factors such as an operation. I actually think that she is having vasospasm, which is very, very well recognized with sumatriptan. And actually it's a contraindication in patients with ischemic heart disease. So the chest pain that she is presenting with are vasospasm from the sumatriptan. It's not surprising that the troponin T is negative, because this is not ischemic heart disease, this is vasospasm, but it's enough such that it is contraindicated in patients with known ischemic heart disease. There's nothing here to suggest melena, hemoptysis, hematemesis, to arrange a gastroscopy, and I certainly wouldn't just reassure her. I think this is a genuine, recognized phenomena, and I would use alternative treatment for her migraines. And on to question number 3. A 34-year-old woman is seen in the diabetic clinic. She was diagnosed with type 2 diabetes 18 months previously and has been on treatment with metformin. Her HbA1c is 6.8% and her blood pressure is normal. She has no microalbuminuria. In spite of dietary advice and modification, she remains obese with a body mass index of 32. Which one of the following is correct with regard to obesity treatment? Here are 5 options for you to consider. Most of them are to do with orlistat. I think what we'll do in this one is go through each answer and consider why it is correct or why it is not, remember which of the following is correct with regard to obesity treatment. Orlistat should be recommended for those with a BMI greater than 30. In general, that is the advice. However, if there's increased risk, so in patients with ischemic heart disease or with obstructive sleep apnea, then the recommendation actually is for a BMI greater than 28. And so it's not 30. And so that is wrong. Dietary and exercise are generally more effective in the long term. Actually, diet and exercise is not more effective in the long term. In the short term, there'll be those gains, but patients tend to regain that weight back again. In resistant cases, combinations of anti-obesity drugs are recommended. Actually, they are not recommended. You take one drug, and if that doesn't work, you move on. So not a combination of drugs. If the patient fails to lose weight on Orlistat in the first 12 weeks, the dose should be increased. And that would be wrong. If they fail to lose weight in the first 12 weeks, the current recommendation is stop Orlistat. What is true, however, is the last point, that Orlistat should be discontinued if the patient gains weight anytime during the treatment, because in effect, it's not working. So just to remind us in general about Orlistat, Orlistat prevents the absorption of fats, and how it does this is that it inhibits pancreatic lipase, and basically all your fat is not absorbed. As a result, you have steatorrhea, and this will cause bloatedness and pale colored stool. Don't confuse this with Reductil. This is used as an appetite suppressant, and actually it's been withdrawn from the market due to increased cardiovascular events and strokes. Orlistat, however, is on the market and is used for obesity treatment. Let's now consider question number 4. A 34-year-old woman with HIV is reviewed in clinic 6 weeks after starting highly active antiretroviral treatment. She has been feeling clinically well prior to starting therapy, but over the last fortnight she's been feeling increasingly tired and weak. She is also complaining of exertional dyspnea. She denies fever, chest pain, or cough. She has no other past medical history of note and is taking zidovudine, AZT, lamivudine, 3-TC, and indinavir, along with cotrimoxazole prophylaxis against PCP. Her hemoglobin pre-treatment was 13.2. After 6 weeks, it's 8.6, with her MCV risen to 102. Her CD4 count has also risen from 205 to 266. So, which one of the following is the most likely cause of the anemia? They usually wouldn't give you a clue, but that's the clue and that's the answer. It's the AZT, and to be more specific, zidovudine, AZT, causes red cell hypoplasia, and this can present with a macrocytic anemia. And so it's not surprising to see that her macrocytes, MCV, has risen to 102. It is not MAI, which is option A here, because her CD4 count has risen. You would not expect to develop an opportunistic infection like that in the light of a rise in MAI, in the rise in CD4 count. In addition, actually, her erythropoietin would not be suppressed. So E is wrong. Her erythropoietin would go up. This has nothing to do with folic acid deficiency. This is AZT-related hypoplasia. Let's now look at question number 5. A 32-year-old patient is admitted with sudden onset severe headache in the occipital region, followed by neck pain and neck stiffness. A CT scan is normal, and a lumbar puncture results in a bloody tap with xanthochromia. And I think you can see on that slide there clear differences showing xanthochromia positive CSF. Which one of the following medical therapies should be commenced? Again, I'll give you a little while to consider these 5 options here. There is only one correct answer. This patient is presenting with a subarachnoid hemorrhage evidenced by the lumbar puncture findings, the xanthochromia. And the treatment for that is nimodipine, which is a calcium channel antagonist which stops the cerebral vasospasm. Labetalol and nitroprusside are used for emergency treatment of a hypertensive crisis. So although in a subarachnoid hemorrhage, you're trying to bring down the blood pressure, the other thing that you're trying to treat is the vasospasm, and nimodipine is effective in doing that. And so that is the only treatment that would be recommended in this particular case. And on to question number 6. A 70-year-old gentleman has been admitted to the coronary care unit late in the evening. Past medical history includes diabetes, hypertension, angina, TIAs, and PVD. He had collapsed at home and on arrival to hospital was in complete heart block. After a few attempts, a transvenous pacing wire was inserted into the right internal jugular vein. During the night shift, the ward staff become concerned as his condition has deteriorated. He's complaining of severe left frontal headache with associated nausea and vomiting. He also has blurring of his vision in his left eye and has noticed some flecks of bright red blood in his vomit. His temperature is 36.9, pulse is 90 and regular, blood pressure is 180/94, RESPs of 22. Examination reveals a fixed, dilated pupil on the left side. There is no focal neurology. His abdomen is soft. Which of the following medication is likely to benefit this patient? Please consider these 5 options very closely. I think this is a very difficult question because it assumes knowledge that is what you would have gathered from experience. He comes in complete heart block. What would you use to treat complete heart block? A pacing wire, and we're told that's the step. But actually there is a step before that. What you would do as a medical SHO, as a medical registrar, is you would probably give atropine to bring up the heart rate. And what he has now is a side effect from the atropine, which has not been mentioned in this question. So the atropine, which is known as belladonna, causes widening of the pupil, dilatation of the pupil as a side effect. And what has that has gone on to lead to develop is glaucoma because of the angle that it results in. Therefore, all the symptoms that he's now presenting with are classic glaucoma. He's got headache, vomiting, pain, and a fixed dilated pupil. So the treatment then for glaucoma is a carbonic anhydrase inhibitor called acetazolamide. That's also incidentally used for the treatment of mountain sickness. So in this slide, you will see glaucoma with a prominent cupping of the disc, but in addition, you might see on the eye some bulging of the actual eye and a fixed dilated pupil. All these would indicate glaucoma, acetazolamide, ophthalmology review, and they would probably recommend topical timolol, not labetalol. Timolol, which is a beta blocker like labetalol, for the treatment of glaucoma. Let's now look at question number 7. A 28-year-old woman is reviewed in the pregnancy clinic. She is 20 weeks pregnant and has a blood pressure of 148/88. Her urine is negative for protein at this stage. You elect to begin treatment for her blood pressure. Which one of the following therapies is the most appropriate treatment? We have ramipril, valsartan, atenolol, methyl-dopa, and amlodipine. Please take a moment to consider these options. So, the treatment for blood pressure in pregnancy is fairly clear. The recommended is either methyl-dopa or labetalol. That's what you would use as first line. Labetalol is a beta blocker, however, it does not have the same side effects of the other beta blockers. So atenolol in this case would cause intrauterine growth retardation. Ramipril and valsartan, ACE inhibitor and ARB, are both contraindicated because of renal agenesis. The only other drugs that can be used are calcium antagonists like nifedipine, and in addition you could use hydralazine if the blood pressure was extremely high and is given in preeclampsia treatment. Those are the 4 drugs that I would use for the treatment of hypertension or blood pressure in pregnancy. And on to question number 8. A 19-year-old woman presents with an infected human bite on her left arm. She says that she was involved in a fight 3 days ago while drunk. On examination, there is a bite affecting the left upper arm, which is discharging pus, and there is a 3 centimeter radius of erythema around the wound. She is pyrexial. Investigations show an elevated white cell count. Rest of the Usenes are normal. Which one of the following is the most appropriate choice of antibiotic therapy? Here are some options of antibiotics to consider. Let's consider the answer, and here's a slide to jog your memory. From the past, Mike Tyson, human bite to Evander Holyfield's ear. When we look at the antibiotics, we must remember which organisms are involved in the human bite. So, Streptococcus, Staphylococcus, and anaerobes. And for all those 3, you want a broad spectrum antibiotic, and the only one that can do that is coamoxiclav or Augmentin. If the patient was penicillin allergic, the only other answer that I would consider here would be metronidazole. But metronidazole alone would only cover anaerobes. In addition to the metronidazole, I would want to give either doxycycline or a clarithromycin in the penicillin allergic to cover those gram-positive organisms. Let's now consider the next question. A 29-year-old patient with chronic hepatitis C infection is being treated with pegylated interferon and ribavirin. He becomes suicidal and is found by his girlfriend having slit his wrists. At previous attempts, he's also tried to electrocute himself. So far, the therapy for his hepatitis C has been very successful, and you are reluctant to stop treatment. Which one of the following is the most appropriate course of action? And I give you these 5 options to consider. Would you stop the medication? Or would you change to lamivudine? Or would you change to unpegylated interferon? Or would you consider psychiatric counseling and antidepressants? Or would you change to amantadine? I think in here, we're told that the patient is doing very well with his treatment. So you are reluctant to stop the treatment. I wouldn't give B, because B is the treatment for hepatitis B, not for hepatitis C. Changing to unpegylated interferon is not going to stop the side effects. The side effects, the depression, the suicidal ideations are because of the pegylated interferon. So what I would do is stop the PEG interferon, but carry on with hep C treatment, and I would use amantadine in this case. Amantadine has shown to have variable success, up to 27%. I think just giving him an antidepressant at this stage and carry on with PEG interferon is not an option, because he has tried to slit himself, he's tried to electrocute himself. I think it's enough to say move away from the drug. So I would say the only option here is go for another drug which doesn't have the same success as PEG interferon, but hopefully, given that interferon has done the groundwork, amantadine can then continue in there. You wouldn't stop the ribavirin, remembering that the ribavirin is not contributing to his depression. Ribavirin in this case would cause anemia as a side effect, and he has no expression or any presentation, symptoms or signs of anemia. On to question number 10. A 74-year-old man is admitted with urinary retention and symptoms of urinary tract infection to the elderly care ward. He is commenced on IV coamoxiclav, but remains confused on his second night in hospital. You are asked to review him with respect to intervening to his confusion. On examination, his blood pressure is 141/70, his pulse is 82, and he's pyrexial. He is agitated and confused, telling you that the nurses are out to get him and trying to leave the ward. Investigations, he has a white cell count that is elevated, and he has mild renal impairment with a creatinine of 149. Which one of the following is the most appropriate initial step in his management? And here are 5 options to consider. I think all these options are reasonable to consider, but there is only one really which I think is the right answer. Haloperidol and lorazepam we do use in the acute management of delirium, and if he was aggressive, I would suggest either one of those 2. I think olanzapine and risperidone have been associated with cerebrovascular disease, and therefore they are contraindicated in the elderly. However, actually what this gentleman needs is a stable environment, one-to-one nursing with the same nurse that he can recognize in a safe environment where temperature is controlled and his temperature and the light is controlled. I think it's more the disorientation in the elderly that brings on delirium, and we shouldn't rush to giving drugs such as haloperidol and lorazepam unless there is obvious psychotic symptoms and aggression. I think changing the environment, controlling that, is more appropriate, and I would recommend that you try that the next time you have a patient who is elderly presenting with delirium.